I'm Pallav Patankar from the Digital Bharat Collaborative, and it gives me great pleasure to welcome you to the first episode of Building Bharat Dialogues within the Digital Bharat Collaborative and for Piramal Foundation. It's going to be a journey for us to discuss about, our way forward for Viksit Bharat and the efforts which we will be taking from technology programs perspective, and how do we progress in building these journeys. Uh, these journeys require us to liaise with governments, with key stakeholders, with key institutions to take this work forward and to build the country in our process, using women and youth as some of our key actors in this process. As I say that, I would like to invite to the forum our CEO of Digital Bharat Collaborative, Mr. Ishmeet Singh. Welcome, Ishmeet. Thank you for being with us today and sharing your insights into some of the great work that we do. What are your first thoughts when you think about Digital Bharat Collaborative and the work that you're doing on the ground right now?
Thank you, Pallav. Thank you very much. And thank you very much to all of you to give me an opportunity to be present here and to discuss some of our work. I think the entire effort which Digital Bharat Collaborative does, I think it's a big gratitude to the ground and field teams who actually put together and work with a very dedicated set of stakeholders in the government who actually make a lot of this change happens. The entire focus of Digital Bharat Collaborative in our journey of building Bharat, it's really about how do we, get the right set of technologies which will accelerate the information systems which are required to transform the public systems responsiveness and governance, which is actually going to impact the services to the citizens, whether it's in the domain of health or education, which are two very critical state subjects. We really feel that if we are able to help build the state capacity to deploy those technologies which are currently available, that itself can help improve the efficiency of the system, the responsiveness of the systems, as well as the governance of the programs. I think the government is putting tremendous effort and budgets to actually deploy some excellent programs which will improve the health outcomes, the education outcomes. But actually making sure that those monies are being spent on the right elements, and the information coming from the delivery is actually helping improve the programs further through proper governance becomes very, very critical. And that, I think, is the most important effort our field teams are putting into making sure those technologies are adopted, those information systems are available to the right set of actors, and to make sure that they're able to enabled and empowered to take those decisions which will improve the service delivery to the citizens.
That's amazing, but I'm more curious to understand, especially because these are programs which are being run, in parts of the country which may probably not have, the most digitally literate or the most digitally savvy individuals. They are on the ground. How do we then use technology in the right manner, and how do we bring in effectiveness into the system, like you just mentioned, in a space which may probably not have the right digital infrastructure? And how do we arm then these actors, if we were to take it down, be it the ASHA workers, be it the ANMs, the auxiliary nurses and midwives, or if you're talking about field level workers who are acting on the ground, or even the government actors. These become essential systems for bringing in efficiency. What do you foresee in terms of where do we have roadblocks right now, and where do you feel that we can make that difference to actually enhance this efficiency going forward?
Yeah, I think that's a very important aspect of it, because if I were to sort of maybe start by understanding these challenges to a bit in terms of what are the challenges of accessing healthcare in the remotest areas, One, of course, is sheer geography. The fact that India is not just the tier one cities, there are many, many cities and many remote villages where the population stays. The availability of resources, which start from roads, networks, as well as, of course, HR in the facilities, is a big, big challenge, and that's there. The sheer availability of the infrastructure. Are those health and wellness centers there? Are those primary healthcare centers available? How far are they from the villages? And what amount of population are they covered? Are they benchmarked against a certain number of population and number of villages in their geography? What are the kind of roads and available? What are the kind of networks available for the people to actually access those populations, those centers? Then, of course, in the centers, what are the kind of facilities available? HR is, of course, the obvious one, whether it's nurses, pharmacist, or a lab technician, or the doctors, accessible doctors, specialist doctors availability. Then there is also in the question of what kind of equipment is available, and if we are actually trying to use a technology, whether the technology can be connected through a mobile connection or a fiber connection, whether there is an availability of those connections. So, and then, of course, the most important part, accessibility of medicines. Are the medicines available in those areas? So I think the four key factors which I always measure the accessibility of healthcare services in a geography is driven by the availability of doctors, accessibility of ambulances, the availability of diagnostic equipments, and availability of drugs. So this whole DADD becomes really the crux of the challenges which we face today in the rural areas, and that's where the test of any government program comes in. And to be fair, I think the government is actually having some fantastic initiatives, both digital, non-digital, infrastructure related, HR related, which is to ensure that the remotest of areas are able to access all these facilities.
It's interesting that you mention about government initiatives and the government doing a lot. One has heard about the ABDM programs. One has heard about empowering the health worker, the ASHAs, the ANMs. What has been your experience in terms of taking these programs forward? If you were to highlight any barriers that going forward, would be great to hear from you about that.
Yeah, as you rightly said, the government actually has initiated some great programs and allocated a lot of budget, especially after COVID, on the health initiatives. I think the biggest challenges in the implementation of these programs. The fact that whether it's an ABDM which talks about a digital infrastructure, or it's about any other programs regarding an RMA, mother and child health, etc. I think one of the biggest challenges is the digital capabilities. And the capacity in general of the human resources across the health systems, especially in the districts, blocks, and the frontline workers. And so this digital capability not only comes in the way of understanding the digital framework or digital health initiatives, but also in terms of the adoption piece. Then the second part from a program perspective are the governance gaps. The fact that the information systems are so weak at the moment, a lot of manual reporting, siloed systems are running, which are actually, impacting the quality of data which is flowing in the system, which therefore impacts the quality of governance which happens of these programs. And because no data is being captured real time at the point of service delivery, everything is de facto captured in some register, which is then copied into some systems, and then the data entry operator puts it in some application. By the time this information reaches to a decision maker, it could be as late as a month. And after a month, any information taken will not have the same kind of impact unless the real-time information was available. Then there are many policy gaps as well, because you want to empower the citizens, empower the health workers. Then what are the kind of incentive structures we have? What are the kind of HR we have there to implement a certain program in the district? The lack of quality information available, the lack of having a policy which ensures that all the HRs are deployed as per the benchmark which you are defining in the policy to cover all the population, leads to further gaps in governance, leads to further gaps in implementation, and further gaps in adoption. By any standard, especially in the, I would say, underserved communities and the marginalized states, the bottom quartile states the utilization of any program budget is not more than 30 to 40%, which basically means that 60% of the budget which the government has allocated for that program is going back unutilized, which basically means 60% of the mothers who are supposed to given an incentive for institutional delivery, safe delivery, is not being available to them. That means 60% of the women don't know that if they actually go in for an institutional delivery, they are given an incentive by the government, and that institutional delivery will be more safe for them and for their child, which obviously then impacts the health outcomes of that area. And that actually is really the issue which we have. As I mentioned, the adoption, the quality of HR capability and HR capacity, their digital capability for any of the new digital health applications, manual data, the governance of the programs, all these are big challenges which we face today in actually coming in the way of implementing of the fantastic government program which are otherwise thought through very strategically in Delhi.
So that's great perspective, Ishmeet, because I think one of the things which we identify is obviously there are these gaps, and one has to mitigate these gaps, going forward. And correct me if I'm wrong, but then I think then the way forward would be, how do you collaborate not only with government stakeholders, work with government stakeholders, but also bring in then private technology companies or private organizations who can then, bring in their expertise to bridge these gaps, taking it forward. How do you think about that? Would that be the possible way forward to use these skill sets to address, these digital skilling gaps within these spaces?
Yeah, Pallav, thanks for the question. I think it's very important to identify the gaps in the intent and the outcome of the service delivery and governance. Because as I mentioned, the intent is very good. I think they're fantastic programs which are being designed, but the outcomes are not coming in. And I think it's important, therefore, to break down who are the key stakeholders and institutions which are actually the actors in this space, which we need to address. Let me start bottom up. Obviously, the field workers. The frontline field workers are the most critical element. We have a fantastic workforce, and COVID actually was an excellent evidence of that, where our ASHA workers, the nurses, auxiliary midwife and nurses, ANMs, they played a fantastic role. Then you have a community health officer coming in, you have the Anganwadi workers. So you have a huge fleet of over, I would say, in any state of large population like Bihar, UP, etc., would have over 200,000 or 250,000 of these frontline workers. So building their capability, digital, programmatic understanding, their ability to handle complex programs, their ability to communicate that to the citizens, their engagement and their capabilities to mobilize the population and the communities becomes very, very critical. Then you come to the second one, which is the health institutions and the health facilities, both at the block level, which is obviously the closest to the community, the district level, the specialty hospital institutions, and the enabling institutions, but like the district health society, the NHM, state NHM bodies, the State Department of Health. These are very critical institutions, and the stakeholders in these institutions, the position holders, are really the ones who are driving the program. So their capability, their understanding, their agency to serve becomes very critical to build. Then we come to the government and the policy and the program design. As I mentioned, the government has put in a lot of resources together to design very good clinical programs. But the real challenge comes in is when you're talking about technologies, when you're talking about AI coming in, you have all the new age innovations coming in, getting the right set of private partners to partner with these governments becomes equally critical. On one part, the program design, on the other part, getting the right set of knowledge partners and technology partners coming in to support the building of that stuff. Then when you look at technology, then there's an element of the infrastructure piece. So while there's a great application which somebody has built, or there's a great point of care device, but in order to deploy that, there is a certain level of digital infrastructure required at the state level, which is starting from a state data center, starting about data security and privacy protocols, What are the compliances as far as the infrastructure is concerned? How do you ensure that the data which is being collected is being secured properly and is available across the system in an anonymous manner, safeguarding the privacy of the citizens, at the same time supporting the right decision making. So it requires a fairly complex digital infrastructures, which currently the capability on the state stakeholders is not there. How do we support that? Then comes to the fact that how does the entire system engage with the communities? So you've addressed the facilities, you've addressed the district program managers and the program staff, you've addressed the health workers, you've addressed the frontline health workers, you've addressed the digital infrastructure and the policy makers. But all of this needs to converge at the citizen end. What are the platforms available for the citizen to interact with these systems? What are the mechanisms and platforms available for their feedback? How can they hold the system accountable? How can the system hear the voice and the grievances of the citizens? How does the citizen actually access this information, their information, to be able to drive their choices? How does the private sector engage with this information? How does the private sector engage with this information? Today, one of the key outcomes government programs want to drive is the limiting the out-of-pocket expenses as far as healthcare and education is concerned, to provide good quality clinical care. But all of this depends on if the citizen actually trusts the system. So what are the platforms available and the systems available to actually build that trust with the citizen becomes equally critical.
So that's great to know, Ishmeet. And I think if I hear what you're saying and if I were to summarize, the way I understand this is, one is obviously the ground level work that we are doing, empowering the local health worker becomes extremely essential. Understanding what the key stakeholders are, who are going to empower them, what are they going to bring to the table. How do we empower government institutions in terms of, I think from what I understand would be a data-backed decision-making process. I need to have information, data at the right time to be able to take decisions to be more effective on the ground. And to do all this, I need the right collaborations. I need the right partners. I need the right technology investment. I need to have the right skill sets, bring it all together, identifying the skill gaps, identifying where the gaps are, be able to solution for that. I would be very keen to understand how, as Digital Bharat Collaborative, what is our way then to, address these issues on the ground, and how are we able to make that difference?
Great. Thank you very much, Pallav, for the question. I think in order to address the gap in each of these set of actors and stakeholders, our programs are designed in a manner to be able to then take each set of actors at a time. Let me again start with the frontline workers, because that I mentioned are the critical element to connect to the communities. So we ensure that we are able to get the right set of job aid tools, whether we design them ourselves or there are partners available in the ecosystem, or the government actually has identified some key agencies and created those job aid tools. But the idea is, how do we take the job aid tools to engage with the frontline workers, ensure that they understand those job aid tools have the right user interface for allowing them to actually use them, so that ASHA worker Geeta Kumari in Chhapra district in Bihar is actually able to enumerate the entire population in her village. She can identify the pregnant women at the right time in the cycle, make sure she's able to assess whether she is a high-risk pregnancy or not, and be able to provide her the right set of care, antenatal care, before her delivery with the nurses in that village. So the job aid tool should be able to facilitate that. Instead of her carrying 20 registered, she can actually have a smartphone with a job aid tool which can allow her to work better. But she needs to have the digital capability to be able to run that tool. She needs to be able to understand how the tool operates. She needs to be comfortable using that tool. That requires certain change management and adoption which needs to be done. That's one of the crux program which we do. Then how does that information travel to the next level in the chain? How does the nurse and midwife get that information? And she knows, okay, I'm having the village health and sanitation day on this day with that village. She's able to inform the ASHA workers, who's able to mobilize the pregnant women to come to the camp and get the required immunization or the antenatal care, which will actually facilitate that care to happen. So then ANM is able to capture her information in a job aid tool available to her, which is called Anmol, which she actually records all the care she's given to that mother. And if there's again a high risk pregnancy case, that's also recorded. And that information then travels to the next person in the chain, which is the Health and Wellness Center, the CHO, and the medical officer in charge there, who actually then they're able to access information and see, okay, in my community, there are so many pregnant women, how many of them are actually high-risk pregnancy cases, how many of them are actually having communicable diseases or non-communicable diseases like their heart and BP patients, etc. So he's able to provide the resources, able to indent the right kind of drugs and medicine required, ensuring that the right diagnostic tools are available at the facilities. So this information available real time is able to facilitate the right decision of having the right facilities there. What does that facility do? How does that facility actually interact with the patients? Having an electronic health system there, hospital information management system, both at the health facilities, whether it's at the block, district, to be able to record all the patients coming there, what are the kind of treatments they are providing, how many doctors are available, how many nurses are available, what kind of facilities are available, the drugs are being given as per prescription, recording those drugs are being given, so that tomorrow you can actually check, okay, this many doctors provided so many clinical care to the patients and so many drugs were actually dispersed. Again, that will impact the projection of the drugs to be available, the HR to be available. The moment a certain benchmark is reached, you know that you need more HR because the traffic of patients is increasing either due to a pandemic or due to a sheer population requirement, which again is only possible if you have real-time data being captured in the facilities through a hospital information management system instead of capturing in a register at the end of the day and somewhere aggregated at the end of the month or the end of the week. By that time, the information is actually not usable for any real-time decision making. And that's only possible if it's there. Then all this information which is being gathered at the frontline worker, ASHA worker, how is it actually driving the program design? How does the district program officer or the state program officer actually know what is happening to his program? How many mothers are being treated? How many patients of a particular disease are there in the entire state? And what kind of program design, incentives, drugs, clinical care do they need to provide for? And that can only be done if that information is being transmitted to them through all these job aggregated and aggregated to them and presented to them in certain manner. So what's the data visualization and dashboards available to the data program officer at the district level? Setting up a complete governance framework at the facility, at the block, at the district, and at the state. And that's where the state Swasthya Samiksha Kendra, which is another program which we have initiated, which comes into play, where actually all the data sets are coming in. And through that control center, as we call it sometime, or Swasthya Samiksha Kendra, the decision makers, whether it's the state program officers, the Department of Health, are actually able to visualize all the data and take the right decision. And just imagine the power of real-time information coming there. So the moment they're able to see that today, the health information helpline, which is 104, which is also another program we run, is actually getting a lot of calls on fever from one district. They're also getting a lot of information that the labs in that district are actually doing a lot of tests for typhoid. A lot of typhoid is being detected. So just imagine, one side they're getting calls for fever on the helpline. On the other side, the labs are reporting that. And the hospital records are also showing that a lot of patients are coming in today for fever symptoms. Bingo, that district has an outbreak of typhoid. What are the emergency measures to be put in to be able to address? Do they need more health workers to come in? Does it need more medicines to be sent there? Does it need more lab technicians to do the test? Is there supposed to be a certain kind of information which the ASHA workers need to start communicating in their villages on what kind of precautions to be taken? All that can be triggered by just being able to having that real-time information available at every level. So the right person at the right time is getting the right information to be able to take the right decision. And the idea is to have these set of interventions across various stakeholders, and wherever required, the right set of technology is bringing that in. But more importantly, whatever technology we put in, the process and the governance cadence has to be put in to ensure that all this information being generated is actually helping in the decision making.
It's also saving resources, right? You know exactly how much resource, and it's not wasted resource. So
Absolutely.
you're
So it brings in the efficiency in the system, it improves the responsiveness of the system, and also empowers the health worker to be able to provide real-time help to the citizens where required.
We continue our conversation with our CEO, Mr. Ishmeet Singh, on all the issues around digitization and building Bharat conversations. Some of the areas which we touched upon were specific programs, and I think a lot of conversation happened around reproductive mother and child health issues. And one of the things which comes to my mind in the previous conversation was the specific focus on mothers and children's health, and specifically in a country like ours where 40% of deliveries happen at home. We have women who are about 50% of the women are anemic. In fact, our government spends huge amounts of monies to ensure reduction of risk in high-risk pregnancies, in terms of ensuring folic acid supplementation for anemic women. We have several efforts which are out there, and we have several organizations who are actually helping out in these processes. But the end result, and something that we need to really look at, is how are these efforts sustainable? Are these program-based, or are these intrinsic to our public health system? How, as an organization or as a country, can we make these efforts sustainable and use digital processes to better govern? And from what we heard from Ishmeet just a while ago, in terms of improving our processes and efficiencies in the system. And in that context, probably I would like to come back to you, Ishmeet, on this. Is how do you think within the Digital Bharat Collaborative programs are you addressing this? Because this does happen to be a large part of how we are addressing some of these issues.
Mother and child health outcome programs are one of the most critical for us, and therefore making sure that our program design addresses this health outcome in a very systematic manner is therefore critical and important. It starts with the first step, again starting with the grounds up. How do we work on the field level program, which is, as I mentioned, the job aid tools which we deploy there, which are specifically designed in a manner where the early detection of pregnancy, so that when the ASHA is making her visits to the household and she's asking her questions and engaging with the women, she's able to understand when the pregnancy starts, and is able to also do the required checklist to identify whether this is a high risk pregnancy, depending on whether the mother is anemic or not, and whether she's able to come for the antenatal care, and works with the nurses to identify the high risk pregnancy cases. So the management and identification of high risk pregnancy cases specifically, in order to ensure institutional delivery or in order to ensure the right supplements, as you mentioned, are being provided, that becomes a step number one. And for that, the digital tool needs to help it, the information flow which is available to the nurse at the right time before the monthly checkups. She's able to provide that input and the supplements to the women, to the pregnancy women, is important. So our programs like the Hushruka, which is happening in Assam, or our programs in Bihar and Chhattisgarh, are specifically ensuring that those kind of processes are incorporated in the job aid tools, and the data coming in there is making sure that the ASHAs are actually doing those processes. And that requires obviously building the digital capacity of the health workers, digital capacity of the nurses, digital capacity of the CHOs at the health facilities, and the medical officers to be able to use those tools, to be ensure that tool gives an alert the next time the ASHA worker goes back, or the next time the HRP mother, high risk pregnancy mother, actually walks into the facility, and she's able to, she gets the required support and continuum of care. Then comes to the next element. How do we ensure that actually when the delivery time comes up, and the ASHA and the institution is aware of the fact that the patient coming in is a high-risk pregnancy cases, the case history is available through the digital records which have been created, and the required inputs and the reading and the vitals which have been measured by the nurses are available to the doctors in the facilities, to ensure that this patient is given the required care and support to ensure a safe delivery, whether it's a C-section operation which needs to be done or whether it's in terms of a natural delivery. But the required care is being taken to ensure that the patient is getting that stuff. Then, as this becomes a scalable operations, how do we build the capability of the entire set of people, the actors in the system, to be able to scale this solution across? So while the checklist of high-risk pregnancy cases or the treatment of anemic mothers is a clinical driven process, but ensuring that those processes are being adhered to, the job aid tools are designed to ensure that they are giving the required follow-up actions to the ASHA workers and the nurses to support the citizen, and the hospitals have the required resources available to be able to address these issues. Therefore, it's important that the capability and the data is available across the system to be able to keep doing this on a regular cycle. Every time a woman gets pregnant, they're able to do those checklists, they're able to provide the supplements, they're able to ensure that the deliveries are safe, they're able to provide the required resources in the hospitals and the required drugs so that those services can be provided. It's important that designing of the entire program and the information systems in the entire district are in a manner where then the system itself can design it. We don't need partners like us or our Gandhi Fellows who are actually supporting the adoption piece to be there on a regular basis. The idea is that after 3 to 4 years of handholding, the system should be able to run on its own.
You institutionalize this within the government.
And it's sustainable.
So thank you, Ishmeet. I think that gives a very detailed view about some of the programs which are actually running on the ground and the tiny details of the program. But what we would also like to understand out here is the way we are spread across, the Digital Bharat Collaborative is spread across states because the local realities or state realities might be different. How do we currently operate across these geographies in terms of defining our programs and taking it forward?
Thanks, Pallav. I think specifically for mother and child health programs, almost our flagship programs in all the states is actually taking this as a very critical health outcome. So as I mentioned, Assam, we have the Hushruka program, which is focused on improving the processes of mother and child health. Then, of course, we have our Darang program, Nirmaya, which is actually focusing on digitizing all the facilities there, making sure that the health records are being created, improving the supply chain of drugs, improving the creation of the job aid tools for every stakeholder so that the tracking of mother and child health and the continuum of care is offered. A similar project is running in Chhattisgarh, what we call the Local Initiatives of Digital Health, LIDH, which is again focused on actually demonstrating complete digitization in one district of Mahasamband, where again mother and child health KPIs outcomes are very critical. And again, we're starting with the processes at the health and with the family frontline health workers, both the ASHAs and ANMs, and ensuring that the facilities are maintaining the right set of health records to provide those services. Bihar, which again has a very comprehensive program across all the districts, health and child health and mother health KPIs are very critical there. In fact, in Bihar, not only are we supporting the digital and governance of all the programs, we are also ensuring that the SNCU strengthening, the FRUs, the first referral units, as well as the blood banks, the entire health system strengthening is the key focus there, and ensuring that not only is just the job aid tools are there to facilitate the ANM and the ANC coverage, as well as the PNC coverage and the institutional deliveries, but also the supply chain, the availability of ambulances, the availability of drug diagnostics across. So Bihar that way is a very comprehensive program across all districts, while we have a smaller program in Chhattisgarh, Assam, etc. in this area. Then of course we have our health information helpline, which we are running currently in 2 states, Bihar and Assam, which again supports the health information available to the citizens. And then, of course, we do a very extensive village outreach program through our mobile medical units, with this government of Assam, which is called Sanjeevani, and we have similarly through other CSR projects running of mobile medical units in many states, which also provides that last mile health services to the citizens.
So it's great to see these initiatives, Ishmeet, across different geographies. I guess one of my next questions is we would like to know in terms of going forward, how do you scale these initiatives up? Because I think that is where you will start seeing impact on the ground, and not just scale them up, but how do you make them sustainable? Because it's essential then that these programs continue into the future and get institutionalized within the government systems, which is as important to us as just demonstrating a particular project. What are your thoughts?
I think thanks again, Pallav, for the question. I think the design of all our interventions in the states and programs are actually, the life cycle is such that where we want to use our focus initially is to make the government align with the stakeholders of the government. I think working with the state governments is a integral part of all our programs, because at the end of the day we have to build their capacity to be able to sustainably deliver the same kind and quality of intervention and programming going forward to be able to achieve those outcomes. The outcomes cannot be delivered by the time a development partner is there. So therefore our focus is to, one, work with the state governments to streamline the process, demonstrate to them, like I mentioned, the district saturation projects we are doing in Assam, Chhattisgarh, Bihar, etc., all to help the local government to understand as to what is the benefit of this entire action activities around digitization or building governance cadence, etc. I think once we are able to demonstrate that outcome in a microcosm of a district and actually show the benefit in terms of the health outcomes, building institutional deliveries, tracking of high-risk pregnancy cases, improving the ANC coverage, PNC coverage, I think that itself allows and builds their confidence that this can be scaled up. So then supporting that scale up becomes important, building their capability becomes important, bringing the right technology partners in the period we are there becomes important, ensuring that the stakeholders at every level, the actors at every level, understand what they're doing, how are they using the tools, and how are the tools being maintained and the data being governed. I think that if that entire cycle could take anywhere between 5 to 10 years, but the idea is that it is important to transition and make sure that we are able to build the government infrastructure and the government capability to do that. And that's the core of all our programming. And I think it's great that the initiatives like the Ayushman Bharat Digital Mission, which the government of India and NHA is driving, I think that becomes the architecture of public health in all the states. And how do we support the states to understand that architecture, implement that architecture? Again, forms a very strong foundation of all our programs.
Thank you, Ishmeet, for bringing up the conversation around ABDM, the Ayushman Bharat Digital Mission, and it's an entire digital architecture which has been framed by the NHA, the National Health Authority, in terms of actually digitizing our health infrastructure, right? Giving each Indian citizen a digital ID for their health, creating electronic health records. Not only that, but also creating a digital record of the practitioners, of the facilities, of the pharmacies, and actually creating the whole digitization of that architecture. I think it has far-reaching effects in all that we've discussed today. What we would like to know is in terms of organizations like Piramal Foundation and Digital Bharat Collaborative, what is the role that we see playing out there from the viewpoint of some of the conversations which we've just had, making this process sustainable, actually catalyzing this process going forward? Where do you see us coming in?
Thanks again, Pallav, for the question. I think, as I mentioned earlier, the Ayushman Bharat Digital Mission, ABDM, is actually a very fundamental program, I think, which not only standardizes the entire digital public health architecture, but also allows all the states to be able to then work against a standardized benchmark of processes, as well as registries, as well as actually a kind of a protocol which is required to establish the digital architecture. And what we do is that as the change agents which we want to play the role and supporting the building the state capacity, I think our focus is that how do we engage with the state agencies, the state NHA body, the state health department of health, to understand that architecture and then actually implement it. While the government of India has given tremendous amount of guidelines, etc., but I think interpreting the guidelines in the local context, ensuring that they create the right PMUs in the team, in the states, to be able to then process do those processes, ensuring that district level, the facilities, the health workers are all creating their health records, their KYCs are done, the record is done, the facility registry and the professional registries are linked to the HRMS system of the Department of Health, so that they are maintained on a regular manner, and that in a form becomes the Aadhaar for all the health workers and facilities in the state. And the same thing is then replicated in the private healthcare space also, which requires to hold camps, to hold workshops for the private healthcare providers, to make them understand the architecture, what do they need to play, what are the benefits they see, how do we engage with the citizens to create their Abha ID. Building, again, the idea is to work with the state machinery to be able to facilitate that processes. Of course, initially we might have to do some hand-holding. Our fellows are actually involved in setting up those camps to do the Abha IDs, etc. But once that system starts rolling, then the district and the block facilities are able to do it themselves. The applications, all of them need to be ABDM compliant so that they're able to, again, follow the same protocols. Even the applications which we have developed, like the Amrit application for the Health and Wellness Center, which has all the 12 CPHC, comprehensive primary healthcare modules in it, it has to be ABDM compliant, so that it actually aligns to the ABDM requirements and ensures that the health records are made as per those protocols. And they become then interoperable. All the data then becomes, it's very essential, because then only the data can actually become interoperable. Patient who is attended by a private healthcare provider and it populates the health record, that same record is available to the doctor in the public health system when the patient goes there.
Their systems are able to read it.
Their systems are able to read it and then offer that continuum of care. The entire principle that if the health system has to provide continuum of care to every citizen, then it's important that all the health record which the citizen owns for themselves is actually available across, whether it's private healthcare system or the public. And that's only possible if there's a common digital public health architecture, and which is what ABDM provides.
So continuum of care is, even if I have accessed at a health and wellness center at a primary healthcare, I have the ability to go all the way to the tertiary hospital or the super specialty hospital, and my health record can be carried all the way there.
Absolutely. And the fact that the pregnant mother, when she goes there, they have their record and they know that she's a high-risk case and she probably needs a C-section to be done because she's not had a pregnancy.
She doesn't have to explain her entire case history.
Earlier ANC records have captured the fact that this is chances are that due to either the placement of the fetus or whatever, she needs to have a C-section. So, and that's something which the patient may not be able to explain to the doctor every time she meets a new face in a public health system.
Absolutely.
But the records itself, so that continuum care is only possible if this entire ABDM architecture has been deployed seamlessly across, ideally speaking, all health facilities and all health workers in the state. And that's what we facilitate and support the state to do it, understand how it has to be done, what is the right kind of technology to be brought in, what is the right kind of hospital information system, the job aid tools, the applications, how are they made interoperable, how does the information carry forward, how does the citizen actually, ABHA ID gets created, the citizen gets a PHR application, which is also a part of the ABDM architecture, a personal health record application, which allows the citizen to actually access which facility is closest to their house, which are the doctors available there, whether all the drugs are available there or not, whether there's an O positive blood available in that facility or not. How does he call for an ambulance? Can he do a telemedicine service to attend to an immediate requirement? All that is available in the PHR, but that can only be provided if the state has implemented the ABDM architecture. That allows and facilitates that PHR app which the citizen gets to be able to provide multiple services. Unless the application doesn't identify my geolocation and the geolocation of the facility is not being mapped under the facility registry, there is no way the two can talk to each other.
So a PHR app would be an end user, a citizen application,
which allows him to see which is my nearest facility,
Correct.
whether that facility has a doctor or not, it has all the drugs, it has the blood, it has the ambulance to send me to pick up, it has the diagnostic facilities available or not. And that's and whether I can do a telemedicine. So all that is possible if that entire public health architecture under ABDM has been implemented seamlessly. And that's the real benefit. So we have not only helped the state governments to implement this architecture, we've also supported in the adoption of the digital tools, as I explained earlier. We've also supported in doing action and communication and IAC information systems to the citizens, for citizens to adopt. So citizens come into the facilities, they are told about the PHR application, how do they use it, what are the options available there. So all that requires a lot of continuous engagement and the right toolkits to be available to all the facilities so that they are able to mobilize and communicate. The ASHA workers play a very critical role to reach out to the citizens. They need to communicate the benefit. So I think the implementation of the public health architecture requires a lot of effort, and helping the states decode it, building their capabilities, allowing the decision makers to do a proper governance of the system becomes very critical.
So that's great, Ishmeet. If I were to put some of all our conversations together, we discussed about the whole ABDM infrastructure. We spoke about RMNCH, and we spoke about the different states that we are working with state governments specifically for their needs in taking it forward. If I were to ask you from a scale-up perspective, if Ayushman Bharat Digital Mission, the ABDM mission, how would you look at that architecture then, scaling up not only for those 5 states, but also taking those lessons to scale it up for the rest of the country? What would be your way forward from the viewpoint of sustainability as well?
Okay. I think that's why, as I mentioned, Pallav, the district saturation projects which we are doing in all our states, and I think that becomes almost like a microcosm for us to establish the proof of concept, not only for that state, but also to take that learnings across to the other 5 states. And we are hoping that over the next 5 years, we are able to implement the proof of concept in a very clear, succinct manner. Show some of these use cases, as I mentioned, of mother and child health, of communicable diseases, non-communicable diseases, and actually show that how this architecture, if implemented in a pristine manner across the public health system as well as the private health system, allows that information flow to make happen and improve the responsiveness and the efficiency of the health system to be able to deliver quality services to the citizens. I think sharing those learnings with every state through either a project PMU structure or engaging with the national NHA and sharing the learnings across, and all the digital tools which we are creating as a part of the DPG digital public goods architecture actually makes those facilities those applications available to all these states becomes a very critical part of our scale up model. Any application which we are using or the state is using, we are making sure that it's open source and it's a digital public good, which can then be replicated by any other state, whether it's for district governance, whether it's for the Swasthya Samiksha Kendra, whether it's for facility certification, or whether it's for the hospital information management system as a part of the district saturation project. All the application, all the learnings are available as a public good for not only the 5 states, but also for the other states through a structured PMU programs. We plan to hold workshops. We plan to hold engagement with all the other states through the national NHA forums and present our learnings to them and openly share our best practices with them so that they can also learn and implement in the same manner. We are hoping this will not only build their state capacities, but also build a sustainable model which can then actually be scaled up across the country.
It's a district saturation program then which speaks about all the elements of ABDM and how do you saturate then a district, ensuring that each and every actor gets
and then that proof of concept gets replicated at state level and the learnings can be shared at a all India level.
Thank you, Ishmeet. I think that was quite informative, the district saturation program. But I want to come back to where we started this conversation from, because at the end of the day, it is all about changing that one life on the ground for that mother, for that individual, to change their access to health systems. How do you see that within this entire framework which Digital Bharat Collaborative
I really believe that if we are able to successfully implement all our programs, just imagine if a lady in a remote village in Bihar is able to, in the moment she actually has an emergency in her house, her husband has had a heart attack. Just imagine that scenario, that instead of panicking, if she can simply pick up her phone, open her app, and actually see which is the nearest facility. And while she's doing that, she actually sees a telemedicine icon there, which she trusts. She presses it, she's able to access a doctor who's able to provide first aid tips to her, and at the same time ensure that an ambulance is dispatched to her house. And while the doctor is actually helping her to manage the situation till the time the ambulance comes, the ambulance is at the doorstep, which is able to take her husband along with her son to the nearest facility, which has the required cardio specialist available to address that issue, which has the blood bank with the blood bank available, which has the required diagnostic facilities as well as drugs available to provide her that support. The fact that if we can actually save that one life, because all this information is available at the right time to the lady, as well as to the doctor, to the ambulance, to the facility, that such and such patient is coming in, suffering from a heart attack, probably age so and so, health record is already defining the kind of allergies that person has or the previous history, actually facilitates that specialist doctor to provide that healthcare that person needs to save that life. I think that every life we are able to save actually helps us feel that yes, we made a difference to the system.
digitization to digitalization to digital transformation to saving lives?
Absolutely, absolutely. That's the potential, transformation potential of the work we can do.
Thank you, Ishmeet. That was really informative. I think it really hit the nail in speaking about our vision mission statement. Speaking about how that vision mission statements then fleshes out into a program, how does it flesh out into ground level activities, but at the end of the day bringing it back again to not just being a program but actually the vision mission that we stand for and why we do what we do to change those lives, to bring in public responsiveness using digitalization, digital transformation in our ecosystem, and making that difference, making that scale within the country, and doing our bit for building Bharat within our Building Bharat Dialogues. Thank you everyone for tuning into this podcast. We would urge you to subscribe to this conversation. We will bring you more insights and other issues, as well as programs about the work Piramal Foundation does and Digital Bharat Collaborative does. Thank you.